Hi, I'm Steve Ollis, the Chief Operating Officer from DTree International, and I'm going to be talking today about some of the work that DTree and our partners are doing to use mobile phones to improve quality at the point of care. So these are devices and applications and systems that we have developed to equip frontline health workers to improve the quality of care that they are providing. This is something that now very few people need to be reminded of, much less people in an mHealth course, but there are a lot of mobile phones out there in the world. Um, More lines than people in some countries. And as mobile phone penetration has increased, have really been taking advantage of this to see, is there a way that we can leverage these devices and their availability, particularly in rural areas, and use that to improve healthcare. Some of the challenges that we are facing and everyone is facing is a huge shortage of health workers. And even those health workers, when they are available, are often not available in the rural areas, and their training and support is not very good. And so that can result in poor quality of care. So some of the other obstacles, of course, are this limited number, a heavy client load. So a particular provider who's trying to see hundreds of clients in a day or a week, which may not be reasonable, limited training and follow-up, high burden of disease, limited financial resources to provide care, and then paperwork, a huge paperwork burden. So for us, just to put the work that DTree does in context, and there are a lot of different frameworks out there as far as different types of mHealth interventions. This is one that happens to break things out into 12 categories. You can see DTree has often focused on the electronic decision support tools. In fact, our name DTree comes from decision tree, because in our early days we were making one-off recordless electronic decision trees that were running on Palm Pilots and Windows smartphones, and of course now everything is Android. And what we are doing is taking Ministry of Health guidelines, who are often based on WHO guidelines, for various care scenarios for sick children or pregnant women or TB clients or suspected TB clients, and helping to put together step-by-step guides or decision trees that help that health worker remember what things it is they are supposed to check for, and then if they detect something, what the follow-up questions or follow-up steps are, leading all the way to a diagnosis and a referral or provision of medication, counseling, and follow-up. But as the technology has changed and the prices of devices have gone down, so now a $50 Android smartphone is very common, and we can store data, much more data on the phones, we've really branched out into a number of these areas. So we are, of course, now have the ability to store the database, a client record on a phone, and so we can reference an entire woman's history as far as her pregnancy as we get into the postpartum period, and have that all available on the phone for the health worker. We, of course, are consolidating the data that's collected during the visits and can report that. We're reporting births and deaths. We are actively working to incorporate sensors and point of care diagnostics into the algorithms that we use, so that a health worker may get the lab results or even a respiratory rate simply by using another device attached to the phone, or some capability like an accelerometer in the phone. We are including behavior change messages to clients and videos in the phones. We are using the phones as a way of connecting providers to each other, whether it's through closed user groups or consultations or call centers. Based on the visits that are occurring, we are helping to support the work planning of the provider, so that they can see, these are the people I saw today, these are the people I need to follow up with tomorrow, these are the people I'm expecting to see 2 days from now, let me get prepared for them. We are also working in supply chain management, as for the health worker, if they don't have the supplies that they need to be able to provide care, even if we've guided them to make the right health decision, but they don't have the commodities or the lab tests that they need, then we've only gone so far. So we've integrated in with some of the supply chain systems, such as C-Stock in Malawi, to be able to help the health worker be able to connect to that system and more easily report on their stock, as well as make sure that the dashboards for our projects help display information about people being out of stock, or can also compare the classifications for different visits with the stock that's provided. And we're also working in financial transactions and incentives using mobile money as a way both to pay for transportation in the cases of projects with community transport and referral systems, as well as a way of using pay for performance. So using the electronic data that's generated from the visits that the health workers are completing, and then distributing money to them using mobile money systems rather than having to shop all that money around. So because of that, we really have been talking for the last few years about building mHealth systems and not apps. One can build an app that does one thing, that does one or two things, but increasingly these, all of these pieces are connected. So a health worker may be connected to other health workers in a facility, or a community health worker, they may be connected to their supervisor, or maybe connected to a call center. And there are many different components to the mHealth system that's being developed. So we've really been focused on mHealth systems and not apps. So a bit more about what DTree does then is we provide mobile health systems for use by frontline health workers. And when I'm talking about frontline health workers, I'm talking about community health workers who may be volunteers, or they may be government community health workers, and health workers at the primary and secondary level facilities. So places where there are not doctors, but these may be nurses or parahealth professionals who are providing a lot of the basic care. We design, test, and deploy applications working with ministries of health and other health NGOs like UNICEF, JPIGO, Pathfinder, FHI 360, who are working to support the Ministry of Health in a certain area like child health or malaria or maternal health. And our focus areas have been primarily maternal and child health, as well as chronic disease. I'm not going to get into all of them today, but just to show you a little bit more, another view of what we've been looking at is a bit of a schematic of looking at some of the challenges that we're trying to address. So you can see in the middle there, we're starting with trying to develop tools to help the health worker provide high quality care. However, they have some additional challenges. There are complex tasks and limited training. So we're developing these decision support applications to support them. But in these health systems, the health workers have additional challenges: limited motivation, isolation, lack of support, minimal accountability. So we're using things like pay for performance, closed user groups to connect them, gamification or recognition as a way to continue to motivate them, and providing feedback so that even if people may not see their supervisor for a few months because they are living in a very remote and working in a very remote area, they can still get some electronic feedback either from their supervisor or certainly within the application. The health system is then challenged by an inability to monitor progress, limited infrequent access to data, and difficulties supervising these remote health workers. So for this, we're providing dashboards, real-time monitoring support, and remote deployments and tracking to make it easier from a central location to see what's going on out there. And generally trying to address this issue of system fragmentation where information is available in silos. And for us, we're continuously engaging with the system and with the data and saying, look, this is what the dashboards are saying, this is what's being reported in certain clinics or in certain areas, and helping to work with program managers and district health officials to help them take advantage of this data. So I'm going to dive back into the decision support side a bit, because as I've said, we work in other areas, but the decision support at the quality of care is still, for the quality of care, is still really the core of what we do. So this is an example of a protocol, of a guideline. So what are these steps that we're trying to get a health worker to do? So this is an example from IMCI, the Integrated Management of Childhood Illness, where according to the guidelines, this is pretty clear. So we need to check, does the child have a cough or difficult breathing? Okay. If yes, then ask for how long. Then we follow a few more steps. We count the breaths in 1 minute. We look for chest indrawing. We look and listen for stridor. We then check danger signs, looking for fast breathing, a few other things, and we arrive at a classification and a treatment. So this is very clear. The problem is that these protocols are often not used correctly. So the health workers don't accurately follow the protocols. these protocols change also. So maybe there's a new medication that's in line, or maybe there's the availability of a malaria rapid diagnostic test that's supposed to be used, or maybe there's a change in policy that says, hey, health workers at this level should now treat for this instead of simply referring. So every single one of those changes requires a new tendering and printing and distribution of thousands of these chart booklets across a country, and that can take quite a lot of time in addition to the cost of changing this. And the health workers, even when they do have these updated materials, they're embarrassed to pull out a book in front of patients. So what people do is they do the best they can. They do what they remember, but like from the IMCI example I gave, this is a 35-page booklet. It's nearly impossible for someone to remember all of that. So the health workers remember the steps that they can, and they miss a few. And then unfortunately, those additional follow-up questions and additional steps are often some of the sickest children. So the question is, how do we get from these complex decision trees and guidelines that exist, trying to cover all of these heavy guidelines and help address this big reporting burden that these health workers have, put them together in an application, and help them so that they can actually provide care to their clients. And so I'm going to walk through 2 examples of some projects where we're doing this, and I'll also talk a little bit more about some of our lessons learned and some of the development and testing and validation tools that we use to make sure that we are following and designing things properly for this complex decision logic. Sure. So the example that I'm going to start with here is from Malawi. This is CCM, or Community Case Management. This is the treatment of sick children 2 to 59 months in the community by health surveillance assistants. And these are HSAs, as they're known. So they run often about a 1-room clinic here, and this is the care that they provide. They do have some commodities. They are government health workers. And the challenges with CCM in Malawi, as in many places, there are studies showing that on a typical visit, the health workers checked for danger signs about all of the danger signs about half the time, did a complete physical examination about 1/3 of the time, and made correct referrals about half the time. So you can see there that the real gap as far as the quality of care that's provided. So what does this look like on the phone? These are applications running offline on Android smartphones that are distributed through our partners to the health workers themselves. And we are assuming that although there is a lot of connectivity in many places where we're working, we are not counting on having that connectivity. So the entire client record and the ability to run the application all works offline. So you can see here that we have the ability to view and see, these are the visits from August 1st. This child came in, they had a fever, they were 13 months old, and we didn't actually give them some medicine because this medicine was not in the medicine box. And that information is always available while they're offline. And this is significant because there are many places where the connectivity simply doesn't exist. Sometimes the power is out for the tower and the data is not prioritized, or simply the phone might be out of airtime. But we want to make sure that regardless of that, maybe we won't see the data immediately on the dashboard because it won't have had a chance to synchronize, but we want to make sure that whatever the case, that health worker can still provide the right level of health care to their clients. This now gets through the sick child form, so this is taking us back through those decision trees. And for Malawi, this is called the sick child protocol. So checking, does the child have a cough? Okay, yes. If so, how many days have they had a cough? Does the child have diarrhea? If yes, how long? Has the child vomiting? Guiding them step by step to getting to what it is that they should do. Another component of the system is being able to take advantage of some of the tools because we are working in an Android system, which is quite a bit open. So we can include things like an automatic breath counter, which had been a reason for referral in the past, where these HSAs simply didn't have a timing device. And in other contexts, although not so much for the HSAs, but in other contexts with community health workers, not all community health workers could count to 54 and be able to keep track for these small children. So we just built in a breath counter into the algorithm that you tap the screen and that records the number of taps, the number of breaths that are that have been counted during a particular time, and then it automatically converts that into breaths per minute. So it's another way of helping the health worker so that they don't have an opportunity to make a mistake, because they often only take the count the breaths for 15 seconds or 30 seconds and then can easily make a multiplication error. Then we move on in the application to provide some medication. So in this case, we are recommending dose for age. We may be recommending dose for weight. We may be recommending a first line or a second line treatment depending on what's available. We may need to take into account allergies. Again, all of these are opportunities for a health worker to make a mistake. So we have the applications calculate everything for them based on the information you've provided. This is what this child or this client should be given. You'll see also we have shown that we've recommended a dose and recommended a medication, and then we have an opportunity for the health worker to enter in, well, what is it they actually did? And you can see that we've given them the ability to say, well, I didn't give the right answer. I'm supposed to give one tablet, I didn't give any, and then to enter in the reason. And part of the reason that we've done that is to allow the health worker to be able to show, hey, I knew what I was supposed to do here, but I need to have a reason to say why I didn't do something, rather than designing a system that doesn't let them move on until they enter the correct number, until they said they gave one, which would encourage them just to falsify data. So with this ability, they can report why they didn't do something, and then this information is available off the dashboard for supervisors to take action and say, okay, I'm seeing that this particular health worker is seeing children with these problems, but they're not able to give this medication because it's not there. Or maybe because a lot of the caretakers don't believe that this medicine will actually help them out. And so maybe the health system can say, well, next month we need to make sure we have some community outreach events in this community to educate them on the importance of oral rehydration salts, for example. The outcome of the assessment is shown here. So in some cases, we may have home treatment, we may have referrals. We can provide information about the pre-referral treatment that's needed, and then the classifications, the swollen feet or cough with some degree of severity, and then a follow-up. So helping out on the scheduling, maybe 1 day, maybe 3 days, maybe 7 days. We also have the vaccinations here, which is something we added into the application a bit later after the first go-round, because while these health surveillance assistants are seeing sick children, one of the things that they all need to make sure they have up to date is their vaccination records. So we've provided a tool for them to be able to easily keep track of that and then alert them as they're seeing these children on other matters when they need to intervene and make sure that these children are overdue for vaccinations, and either provide them or refer them to make sure they get them themselves. Another component I wanted to touch on now is the issue of reporting and providing monthly reports. In the context where we're working, where these health workers are working, there's quite a lot of reporting that needs to be done. So what we have done is develop reports not only on our dashboards, but also within the applications themselves. So both the health workers, the HSAs, and their supervisors can see in real time all of these different classifications, and see how many children have been referred for home treatment and how many boys and girls. All of these things are available for them on the phone, matching the format that they're required to fill out for their paper forms. So this information, again, is available for that health worker, automatically calculated for them, and then visible when there is connectivity on the HSA supervisor's phone. Another component of the system here in Malawi is integration with the commodities system. There's a system called CStock, which is an SMS-based system where health workers were sending structured SMS, so codes for the 19 different commodities that they were trying to manage, and sending strings of code via SMS to have that report to a dashboard. And the great thing about that system is that it just requires a phone that can send a text message, which all of them can. One of the challenges, however, is that the health workers have to make sure that they actually remember their coding, which is, again, does introduce some opportunities for mistakes to be made. So what we did is we just built a simple interface for this system within the application, allowing them to manage and report their stock. And then our application converts it into structured SMS, and it still rolls back to the same C-stock system, but it's just easier for the health worker, and they can do everything they need to within one tool on their device. So, as I mentioned, we have web dashboards associated with the systems, and here we can really do just about anything, showing activity levels by facility. We can see by user. We can see new patients, how many supervisory visits. We can break down the reasons for referrals by abdominal pain and abscess, and really slice and dice it any which way we want, looking at different family planning options that were provided and why. Really have quite a bit of flexibility. We have found that because of challenges with connectivity and bandwidth, that the dashboards are really more used at the National Ministry of Health level, as well as at the levels of our partners. But for the health workers themselves, as well as their supervisors, really the applications tend to be much better for them as far as reporting. So they don't get quite as much information, but it's something that's renders quickly and is available offline, rather than waiting for some of these charts and reports to generate, because the connectivity is just not very good. So now I'm going to move on to a second project here called mHealth for Safer Deliveries. And this is a project that has, in some senses, a simpler application, but then the health program around it is quite a bit more complex. And we're getting into aspects of community transport systems and using mobile money. So this is a program that we started in Zanzibar actually about 6 years ago, and started as Gates Grand Challenges. We had 2 rounds of funding there, and since then the program has evolved into receiving some Saving Lives at Birth funding from USAID, and has another 3 years to run. This will be your idea based on, or presentation based on, the earlier rounds of the work. So the current system has evolved a bit from them, but we have data to share from this bit. So for the context in Zanzibar, and the problem we're trying to address, is that more than 50% of the deliveries are at home. And this, of course, the home settings in Zanzibar is not as hygienic. You don't have access to the medications you need. You don't have the trained health workers there. And then we're also trying to address the issue of the 3 delays for people getting to health facilities. So the decision to seek care, the transfer to a facility, and the ability to get treatment at the facility. So what we did is we developed a decision support application that equipped traditional birth attendants and community health workers to screen pregnant mothers to identify risks or danger signs. We also established community-based referral systems to transport women in labor. There are ambulances, but they don't tend to be available. They often don't have fuel. The drivers are not around. They may not be functioning. They may be taken for other purposes. So what we did is we mapped out the community transport options available for every village in this project, and helped figure out what boats, taxis, trucks could be available, what the appropriate rate should be for any of their transfers, who the safe drivers were, and made sure that then those negotiations didn't need to happen when people were in labor or having an obstetric emergency, but that everyone knew what the prices would be. We then coordinated payment of transportation to the health facilities and hospitals using mobile banking, so the ability to pay the drivers immediately electronically, and then followed up with the family a few days after delivery during the postpartum period to include postpartum and postnatal care. So the results for this, we moved from about 30 to 40% as it varied facility delivery rates to over 78% facility delivery rate for about 12,000 women. Significantly, I mean, that's of course a very big increase. And an additional portion that we were very excited about was for those women, out of those 12,000 women whose last delivery was at home, 2/3 of those chose to give birth in a health facility. So these are women who were very predisposed to having another delivery at home, but 2/3 of them through the program decided to deliver at a health facility. Another statistic that we were quite pleased to see was that 88% facility-based postnatal care within 1 week. Of course, there are many mothers and newborns who encounter health difficulties during and immediately after delivery, as well as within the first week or so. And that postpartum follow-up, that postpartum visit often doesn't happen. So you can see the statistics where we were getting, before the intervention, a third of the women were coming within the first 6 weeks, and we had now 90% of the women coming in within 1 week. And we also, because of the birth plans that we developed, had increased use of primary facilities where, depending on the risk factors that were associated with the woman, she would be directed in her birth plan to say, you need to plan to deliver at this hospital, you need to just plan to deliver at this local health facility. So we actually had increased use of the primary facilities, with about a third of the women delivering at the primary facilities, as compared to 4% before, where everyone, if they did go to a health facility, would just rush to the top level referral hospitals and really just crowd the place. So we were happy to see those results. Some other questions that come up about our work. I think people can see that the decision support tools may be useful, but there's always a lot of issues around acceptability, both from providers as well as from clients. So we've done some research on this. This is around the facility-based IMCI. Where we we asked the providers what they thought about this, and you can see that the feedback was positive, is that it helped them, helped remind them of the things they were supposed to do, helped them provide additional information that may not be clear on the forms, helped them calculate the dosages of things they were supposed to provide, and really makes the clients and the caretakers themselves feel better about the care that's being provided, because they can see the doctor is asking more questions and listening more carefully to what they're saying. And from the mother's side, again, they may, and we see this in other settings too, there may be a little bit of a wait. The clients may have to wait longer than they did before because the visits are longer. But this is because before, the providers were often just asking 1 or 2 questions and then writing out prescriptions. But today we can see, my child is actually being examined, actually touching the child or removing the shirt to see what's going on. But this time they're actually asking some questions and providing the appropriate care. So although it's maybe somewhat inconvenient from a time perspective for the caretakers or for the clients, they do see the value in having the provider take that time, because they do see that they are getting better service. Now, one of the other pieces I wanted to mention here is cover a little bit of the complexity and some of the technology we use to design these tools. I mentioned IMCI and these 35-page flowcharts of some of the different tools that are there's some of the different pathways people are supposed to follow. And it's challenging for a health worker to follow these, and it can also be challenging to represent these electronically. So we've been working with a tool called Mango Logic from an organization called Things Prime that allows us to work through these and to create tools that non-programmers can use, and also help to share that information with medical professionals who need to validate and see what's going on, as well as providing some testing and validation results. So this just shows a simple illustration of how some of these decision trees can get a little bit complex. So you can see we have a starting point, and then we ask 3 questions, and then from each question there, maybe we can go down 4 paths, and then each of those 4 paths, we can go down another 3 paths. And you can see that very quickly we can end up with a very complex application. So we can see, does the child have a cold? Do they have fever? And from there we move on. So we have a couple of different ways of checking this. So you can see that we have now developed the application. If you look on the left side there, we're seeing the danger signs. We need to check to see if they're breathing, check their airway, see if they're responsive. And we have a simulator on the right, so you can see what this actually looks like on the phone. But you can then see conditions that are being triggered or not in the application. So we can see, this is the section where I'm answering danger signs, and am I triggering any of these conditions that said, oh, somebody has a danger sign or someone has high fever, and see, as I'm answering the questions on the phone, what conditions are being triggered, so we can see if the application in this simulation is performing as we think it will. So that's one way to try to validate this. Another is to produce a review of the records. And this is something that we can then share with both our program staff as well as the medical experts that we're working with at the Ministry of Health and partner level to see, okay, we have ended up, this is the summary. We've ended up with a client who was responsive, but is in fact having convulsing, is convulsing now and is not breathing. This is the classification we have arrived at. Does this make sense? Do you agree? We also have the ability within the application to discuss and collaborate on each and every question. So this is not all that different from being able to provide comments in code. But again, this tool is not designed for coders. This is designed for people to collaborate on medical conditions, and is assuming that they're not necessarily reading code. So you can see in simple language, okay, we have a question that we want to ask about the number of pregnancies that we've had. So these are some of the discussions that now people can go in and have and provide questions and answers about, well, maybe we should ask this in 2 questions, or what do we really mean by pregnancy? And have issues then tracked and resolved in here without the need for someone sifting through lines of code and looking through the comments. Another tool then that we can use is simulations. So we can develop our decision trees and then have system generated simulations that run through and see, okay, in this simulation, we had a child who was convulsing now, this was the age selected, this was their gender, and seeing, okay, did we arrived at possible epilepsy, and then look back and see, is that correct or not? So this is something that I think, again, I've just touched lightly on, but it's something we really spend a lot of time thinking about because there are a lot of rules in the applications that we're working on, and as we are trying to help the health workers make better health decisions, you can also see that if we have any mistakes in these decision trees that we're providing to the health workers, then we run the risk of also providing them poor guidance. So it's very important that as we build these complex tools, we have sophisticated ways of validating that they're actually correct beyond the basic, of course, test plans and taking things out to the field and running through all of that. But we wanted to have some automated tools to be able to improve the quality of the product that we're providing. So just a few additional things I wanted to share from our experience in working in mHealth. There's a fast pace of technological change. I mean, I alluded to this earlier. We were originally working on Palm Pilots and Windows phones. When I started working with DTree about 6 years ago, we were just starting to work on Android smartphones, and they were about $650. And it seemed crazy to think that we would be providing these tools for frontline health workers. And then 2 years later, they were $50. And we've seen that now many of the health workers themselves have nice Android smartphones. Still not a lot of iPhones out there, but definitely a lot of smartphones. So the technology changes. Another piece is that change management is essential. I've talked a lot about the tools and the applications, but for these health systems, we are introducing disruptions, hopefully a positive disruption, but we need to figure out how each and every actor in the system is going to be impacted by the introduction of this electronic tool. So what will the clients think? What will the health worker think? What will the health worker supervisor think? How about the people, the monitoring and evaluation people who now have access to this data? Can the district health staff, can they actually react to this information that's now made available to them? We need to encourage data-driven management. With a lot of these digital tools that are out there, there's a massive amount of data that is now available for decision making, but still a lot of the old ways of using information still exist. So things are aggregated, put in a report, and sent up, rather than people necessarily having the time to do analysis and say, well, let's see if this data actually makes sense, and let's provide some feedback back down to those health workers. Another component is field refinement. So we talked a lot about the guidelines and making sure that the applications follow the guidelines. Another piece of this is making sure then that the workflow is correct. So although we may know all the steps involved in getting from greeting a client all the way through to registration and prescribing and follow-up, we need to make sure that the workflow for that community health worker, that facility health worker is correct, and make sure that they actually have the medicines they're supposed to, the lab operates that it's supposed to. So we design a prototype and then take that out to the field and spend a lot of time working with the health workers to see, does this actually work in the context as they're seeing clients? Because even though we've gone out there, we've talked to the Ministry of Health folks, we've talked to the district officials, we've talked to the health workers, the way that I say I do my job might be different than I do my job when somebody's, actually have clients in front of me or somebody's actually watching me. So it's important to do that field refinement step. Another piece is that users must feel that the application supports them. So a tool that's simply for data collection is wonderful and appealing for a lot of health systems managers, because they feel like, this is wonderful. I can get hundreds and hundreds of fields of information from every health worker every day. But if the health workers don't feel like that application actually supports them in the work that they do, the novelty of using a mobile phone will wear off, and many of them will decide, I think I'm not going to use this. So people need to see that, hey, this application is helping me find clients and be able to see what happened at those prior visits. This application is helping me calculate the correct doses. This application is helping me see when I need to move someone off first-line treatment and onto second line. And so these are just lots of different reasons that the health workers can continue to embrace and use the device. And finally, we've talked certainly about using smartphones and dashboards and integrating point-of-care diagnostics and breath counters, but it's important not to let technology push the program. That we can send automated text messages with information all through the health system, and we can have video conferencing, but sometimes a great thing we can do is just let people call each other and have a nurse or a community health worker call a supervisor and say, hey, I'm having this problem. I'm here with this woman or this child, and I don't know what to do. And these isolated health workers can then have a greater confidence in what they're doing and simply be able to connect just by making the phone call, rather than something that would be more potentially look nicer on a slide and present nicely in a conference, but in fact not be nearly as effective. So just a few recommendations that we have following this is for people who are looking to implement digital health solutions, is to get involved with some of the local eHealth, mHealth, digital health working groups in each country, where you can share information about projects and learn about some of the other projects that are going on. Look for existing projects to leverage rather than coming in and building something brand new. It may be that there's nothing else you can leverage, but probably within a country or even a nearby country, there are at least some similar experiences you can learn from that you can use for your project. You need to adapt each project around the in-country M&E health ecosystem. So you may have a solution that says, well, this is the best solution. We want this in every of the 50 countries that we work in for all of our community health workers. But each country may have made different decisions about what fits as far as their enterprise architecture or their e-health strategies. So we need to partner with the Ministry of Health and consider the entire health system when we're designing these solutions. Of course, plan for integration with whatever the health management information system is from the start. And then another piece is to really look at leveraging not only existing projects, but to look at other digital development initiatives like mobile finance, mobile agriculture, mobile education, and see, hey, are there smartphones out there in the community that somebody is using for agriculture? Is there a help desk for that system that exists in each town or each district that we can leverage? Is there power that's being provided as part of a project, maybe to schools, that the community health workers could use to charge their phones? Because there are scarce resources, and as much as we can combine and reuse some of these supporting tools and supporting processes, structures that are necessary for these programs, we can reach a lot further if we move together. So what's next for DTree? A lot of things, but continuing to integrate some of the work that we do between the facility and the community, where community health workers can share information and client records with providers at the health facilities and vice versa. Integration across domains, and what I mean by this is where we're integrating the community case management. We've now integrated that in with maternal and newborn health, and we're also integrating that in with family planning. So in a single application, these health surveillance assistants now can address at least three different domains of care, encompassing quite a significant portion of the populations they're serving. Continuing to work on the dashboard analytics, continuing to explore usage of mobile money and further integrating in with some of the mobile money systems using their APIs, and continuing to explore integration with point-of-care diagnostics and also unique identifiers. Whether this is barcodes, fingerprints, retinal scans, the ability to identify a client is a very significant one in places where often there are not national IDs. And so we are looking to see how these how these new tools that come out are available at different price points and have different power and durability considerations. So one last bit I wanted to end on here is just an example of kind of integrating some of these tools of mobile health and mobile education, because there are a lot of mobile tools out there, and maybe this is a mobile education tool where we say, aha, we're going to put a bunch of videos on a phone, and that's going to be the way to help a health worker. And we'll say, well, we have this decision support application, and that's going to be the way to help the health worker. And now, let's see if we can actually combine these two. So at the time when we are asking a health worker to check, is there chest indrawing, they might have a link where they can click and access, oh, this is the definition of chest indrawing from a medical dictionary. Or to be able to view a short video about what chest indrawing actually looks like. So being able to make these electronic tools available, not just on the phone, which is still a big improvement from people not being able to access them at all, but can we make them available actually at the time when a provider is running into this particular issue or is being asked to make a judgment about whether or not there's chest indrawing. So this is just an idea that I wanted to illustrate about some of the possibilities. So with that, I'll say thank you very much. Contact details are here. Would like to hear from some of you all to hear more about your experiences or get some of your thoughts on the work that we're doing, and good luck. So thank you. Yeah, it's an important issue, and this is why I think it's all the more important that different projects can work together, because the reality is there is still many things are driven by project funding, but so you may have different partners working with the same community health workers, the same health facilities under different programs, and a lot of them are using digital tools for one reason or another. So it may be that, say, under a program with DTree and Save the Children, we worked together and we built these decision support tools under another, and that ran for 2 years, and then the funding ended, and we've trained everyone. We have trained trainers, and we have champions within the system who can provide some troubleshooting. But then somebody else may come in and say, we would like to have a data collection system, and we're going to equip the health workers with with a smartphone to report data. To say, well, why don't you reuse, you already have trainers who know how to orient people on smartphones. We already have these devices. We've already pre-negotiated a preferential rate with Airtel or Vodacom or whoever it is. So why don't you leverage that rather than starting something fresh? So I think the key is to find as many different players who will benefit from having these systems in place, and also to make sure that a lot of different people are seeing the benefit of it. So make sure that the health workers, even after the project ends, they'll continue to use the applications. That the clients will say, hey, put me in the phone, as they say, I want my child to be seen with the phone. And that the health system supervisors will continue to say, hey, I need that data. I now, that data that I get every month, I can't wait 6 months the way I used to get it, and I'm going to give you feedback there. So I think by working together with other projects and partners to help them leverage some of the investments that have already been made, and also have the applications and tools be useful to various levels of the health system, it provides a lot of different avenues for people to continue to use the tools even after one project might end. Yeah, it's something that we're really actively looking at. I did touch on some of the challenges. I mean, in different places, a lot of the work is done via sensor. You go to the hospital and you're instantly hooked up, with sensors on your chest or your abdomen or your head, and you're being monitored in that way. And I think those things can be very useful. I think you just run into a lot of the same issues that you do with introducing any technology, particularly things like smartphones, where you may have a device that works very well, but does it, does it have to have power all the time? How much does it cost? If it breaks, where can you get replacement parts? Even if there is something that's available that could plug into a smartphone, how much of a drain is that going to be on the battery? So it's something that we definitely see as coming. We welcome it, and what we would really imagine is then incorporating these different devices and tests into the algorithms. So rather than asking the health worker, oh, please input the result of that malaria rapid diagnostic test or of that urine test, we are providing instructions to the health worker on how to prepare the samples, and then how to plug in the device. But then the device is doing the work and providing the answer, and then the algorithms and the applications take that result, factor in the three other physical signs that you've identified and the client's history, and help arrive at the diagnosis. Oh, it really is. I mean, we think about various programs, right? And so maybe we're focused in health. We're very focused on the pregnant woman. So this pregnant woman, well, chances are, in many places in the world, she's a farmer, and her partner, if she's married, there's a good chance that he's a farmer. They might have, this may not be her first pregnancy. They may have children of their own, or other children that they're taking care of. These children need education. The farmer needs information on crop prices, or even access to information about what to do if they see a particular type of bug growing on their crops. So if somebody is visiting door to door, providing community information, or mapping households, or any of this, could they use the same device? Could they also be equipped to help, to provide people with better information, whether it's about education, whether it's about agriculture, or whether it's about health during those same visits, or at a minimum, look to leverage some of those investments that have been made, so we can say, yeah, we've mapped out every single school in a country, and it is right next to every single health facility, or a particular project, a water project, mapped out every household in 3 regions, and that data and information is incredibly useful then in a health or an agricultural setting as well. So whether it's combining tools in the hands of now a community worker, or just simply sharing the data so that another program doesn't have to go about spending the money on collecting that same information, I think there's a lot of potential. There was a program from a few years back, actually. It was a Grameen Foundation had a program with the Village Knowledge Worker. And this was, I believe, in Uganda, where they did combine agriculture and health messages, where they did have a community knowledge worker who had access to information about both agriculture and health, that they were able to provide to the community from the same device. And I really thought that was very innovative at the time. I'm not sure if it's actually still continued, and I have not heard a lot of other similar programs, but it's something that, as you can tell, anywhere I have an opportunity to speak about it, I bring it up. I still think it makes a lot of sense, but it involves not only people reaching across silos and programs in one area like health, but people both in government, donors, as well as with implementing partners to reach across, out of my health unit and reach into agriculture, reach across over to education, and see if there are ways we can work together. So the problems are solvable, but as with many things, technology will, can get you so far, but we still have to deal with real people.